screen there. So, right in my...
All right, can you guys hear me next door? I like the skeleton in front of the camera there. Really can't tell what's going on in the room, but that's okay. All right, so the plan for today, we're going to finish up my portion of the block with hypothalamus and pituitary. We allotted 2 lectures for it today and tomorrow. Anterior pituitary is a lot more in depth, a lot more hormones to discuss than posterior. So the plan for today is to get through anterior, which is a lot of material, or the concepts are more than the posterior pituitary. Wherever we end with anterior pituitary, whether that be the first hour, whether that be mid-second hour, or the whole 2 hours, however quickly we get through anterior, we're going to cut it off, right? And then tomorrow we're going to do posterior, and then I think we'll have plenty of time to briefly do a review on what you've gotten from me so far. And then we won't meet Friday. Monday, Major Hart is going to give you diabetes on Zoom. I think it's going to be on Zoom or Big Blue Button. One of them will work it out. And that's we moved some things around for Monday. So you have your neuro test Monday, correct, everybody? And then Major McMahon's going to start his next block right after it. So then after lunch will be Major Hart, from 1300 until complete. And then you'll have the rest of that week next week to get ready for the test on Friday. So I think you should have plenty of time with the material because you won't be getting anything new after this weekend until Monday. And it's only diabetes. It's very focused, and then you have those 4 days to prepare. So without any further ado, let's jump into the hypothalamus and pituitary. So basically, we're going to be talking about a review of hopefully what you can recall from A&P, right? All those hormones that are released by the anterior pituitary, the posterior pituitary, the hypothalamus pituitary axis. Hopefully that's ringing the bell, right? Everybody's remembering that. We know it verbatim. We could draw out the pathways of the hypothalamus pituitary axis right now, and we don't need any of these lectures, right? I'm sure. But hopefully we're going to put it in buckets to where you can recall it. You have to understand that normal physiology to understand pathophysiology so we can get to what the goal of this lecture is, which is the pharmacology, right? So a lot of concepts have to be pulled back. This is when we really start stacking and scaffolding the lectures you got in first semester, this semester, and moving forward. So have to know what the hormone does and what normal phys looks like, normal physiology, to understand the pathophysiology, and then how do we get after that with medications. So you've already learned about growth hormone, ACTH, TSH. We talked about TSH in the last lecture. FSH, LH, prolactin, right? Oxytocin. You know it all. But we're going to review it and make sure you do. So for Pharm, this will be a little bit more of a heavy phys and pathophys than we normally see. But hopefully it's a review and you go, we didn't need that anyway. But for those that do, we will get there to make sure you're masters of the hypothalamus and pituitary moving forward. Pretty simple concepts with hypothalamus and pituitary when we think about, pharmacology. Are we replacing something that our body's not making enough of, i.e. the hypothalamus or the pituitary is not making enough of, or are those glands making too much of something, so we need to antagonize it, right? We need to antagonize those increased abnormal productions of certain hormones. Or are we going to use a medication, sometimes a synthetic medication, to conduct a test that will let us know an underlying cause of a disease process. So we'll talk about all those buckets. So nothing new here, but just remember, use this framework. Don't forget about the ELOs, right? When we talk about what's the purpose of what we're learning, because all of those 7 bullets are basically how it's going to show up on our tests and how Pharm is going to show up on your pants. So starting off with physiology, hypothalamus is a master regulator, integrates autonomic and neural input for things like our temperature, our circadian rhythm, or our normal day-night rhythm, right? Limbic input, like our emotional system, right? Limbic system. Translates into hormonal output versus pituitary. Remember the two lobes of the anatomy, because it's very important when we discuss the anterior pituitary versus posterior pituitary, because of what those lobes do, right? Anterior lobe, adenohypophysis, and the posterior lobe, the neurohypophysis. So the big difference there, anterior lobe, true endocrine tissue, synthesizes its own hormones. It's under hypothalamic control by releasing and inhibiting hormones, right? The posterior lobe, not a gland at all, right? Posterior lobe, the neurohypophysis, not a gland at all. It's axon terminal, it stores and releases, and the reason that the posterior pituitary discussion is so much short, there's only two hormones that are stored and released there. Not made there, but stored and released, and that's ADH and oxytocin. So a little bit more straightforward, but very important hormones from the posterior pituitary release. But those hormones, ADH and oxytocin, actually made in the hypothalamus. So that's why this lecture is going to look very different. That's why we'll break it into anterior versus posterior pituitary today. Right? When we think about anterior pituitary, we're looking at the releasing hormones and the trophic hormones, i.e. regulating function in our body and promoting health of the glands. And then their analogs or antagonists. And then for posterior pituitary, we're just talking about the ADH and oxytocin that's released and what mimics them and then what antagonizes them, right? So for the anterior pituitary, a clinical pearl you need to remember for the anterior pituitary is that it synthesizes hormones, right? Glandular tissues. So tumors here cause either a decrease or an increase in secretion syndromes. Whereas because the posterior pituitary gland only stores and releases those hormones that are made by the hypothalamus, the posterior pituitary failure is really a central problem, right? A hypothalamic root cause, because the hormones aren't made in the posterior pituitary. So just remember that the posterior pituitary is not an endocrine gland. It only stores and releases the ADH and oxytocin. That comes up throughout the discussion, right? All right. So here it is, straight out of A&P probably, right? Probably the same exact slide, hopefully, so we can kind of reinforce the same learning concepts, right? So the hypothalamus pituitary axis, quick review, not so quick, right? Lots going on there, right? So you don't have to memorize it, but you definitely need to know the target organs, right? Those target organs, and then what hormones affect them. Some hormones affect numerous target organs or throughout the body, and we'll talk about those hormones. And then knowing, is that coming from the release from the posterior pituitary or the hormones that are made and released from the anterior pituitary, and then what releasing hormone is coming from the hypothalamus to go down and affect the pituitary to cause the release of the hormones, right? So basically the review is that, we have those neurosecretory neurons that are in the hypothalamus. They're going to release those hormones. In the case of the anterior pituitary, it's through vessels, right? Do we remember that there's actually a vascular system from the hypothalamus to the anterior pituitary, in contrast with the posterior pituitary, right? So an example on the left, if we're looking at the chart, is that the GHRH is going to travel down through that portal system, so the hypothalamus to pituitary blood flow, those vessels, and it's going to stimulate somatotropes. And then we're going to get growth hormone released into systemic circulation that act on those target organs, right? The first box there. right, on the left. And that's the liver and the growth plates in the case of growth hormone from the anterior pituitary. Now we contrast that with posterior pituitary. An example would be ADH, right? ADH and oxytocin synthesized in the hypothalamus, and then they travel down axons, not the portal system. They go through axons into the posterior pituitary where they're stored and then eventually released. This is just a 5,000 foot view of this, and then we're going to dig into each of them. But get lost in the sauce, come back and review here, right? Because if you know those target organs and what hormone is affecting them and where they're released, then you can kind of either mentally or on your scratch paper draw it out to make sure you know where we have a disorder, right? Where something's either hypofunctioning or hypofunctioning, hyper or hypo, too much or too little, so that we need to shut it off. And where do we shut it off in the HP axis? Or where do we need to add more in because there's not enough's being made? If you keep those concepts and understand the flow, then you can pretty easily work through the diagram in your mind or on a piece of paper and know, hey, I understand this sequence in the HPA, so I know now whether I need to throw some more in or take some away, and where that something you're either inputting or taking away is acting, right? Whether it's going to be up at the hypothalamus or in the pituitary or down at the target organs. And we have cases of all when we talk about the HP axis. So make sure you recognize those downstream organs: ovaries, testes, bone, mammary glands, the adrenal cortexes on the adrenal glands, thyroid, which we talked about yesterday, renal tubules, and the uterus. Because every drug that we're going to discuss is going to act at one of these or cause a reaction at one of these end organs. So one thing that we are going to discuss as we go through it, but I'll make you aware of it now, is like an exception, right? So we talk about the HP axis. When we talk about almost every other hormones, we're going to stimulate their release, right? But there's one, do we remember which one is reverse inhibited, right? Where there's a hormone that its secretion actually keeps a hormone from being made. Does anybody remember what that one is? Any guess? So dopamine would be the inhibitory. The dopamine is the inhibitory from the hypothalamus, inhibiting the release of what? Prolactin, right? So we're going to hit that one again. But that's your exception. I bring it up now so that as we work through it, you remember when we get to it, oh yeah, this is different, right? Dopamine is inhibited prolactin release constantly. When you decrease the dopamine effect on the anterior pituitary, then prolactin is released. So we're going to talk about that as the exception as we move through the lecture. All right, this is a negative feedback loop that's really just a template, right? Just a template. This one is using the corticotropin releasing hormone as the example, right? Starting up at the hypothalamus. But for every anterior pituitary axis, anything that's on the anterior pituitary axis, we can kind of use this as our diagram, right? So we're going to use the cortisol as the work example. The hypothalamus is going to release CRH, right? Corticotropin releasing hormone. And then the anterior pituitary, after that stimulation with the CRH, is going to then release the adrenocorticotropic hormone, ACTH, which has the end organ effect on the adrenal cortex, right? And then finally, that end organ releases cortisol at the adrenal cortex, from the adrenal cortex. And then the cortisol is what is the inhibitory factor in the negative feedback loop in this HP axis, right? So as you're working through, specifically anterior pituitary, when we talk about all of the hormones from the anterior pituitary substituted in this axis, right? So if we want to mentally substitute TRH, right? So if we put TRH from the hypothalamus, then that's going to the anterior pituitary to release what? Do we remember? Just yesterday. TSH, right. And then we're going down to what's the target organ of the TSH? Thyroid, which is going to release. All right, our work is done here. We're good to go. Just kidding, right? You can do the same thing with GnRH. And that's not what we're going to do in class all day, right? This is what you need to, when you're studying, substitute it in. Make sure you understand this axis, this feedback loop for all of the anterior pituitary hormones, right? And then you got it licked, because whatever we ask, whatever the board asks, then all you got to do is mentally substitute in the HP axis for whatever the releasing hormone is from the hypothalamus to the anterior pituitary down to target organs. That's why that last slide becomes important to own those end organs of the pituitary hormones. So half the battle is just knowing where in the loop is a drug going to act when we talk the pharmacotherapy, right? When we talk the pharmacotherapy for hypothalamus pituitary, half the battle is understanding this, so you can then go back, where is this drug acting? Is it inhibiting? If it is, where in the axis? Or if it's stimulating, if it's an agonist, where in the axis? And then knowing what that does to the target organ, right? So if I were practicing this, I would just practice going through all of the anterior pituitary hormones, right? Either working, from the end organ and what's released backwards, or starting up at the hypothalamus and working down. Know it both ways. So really here we're looking at the table of contents, right, for the lecture, for the HPA, for the hypothalamus and pituitary axis. Just the hormones that are released. This should be a review, but this is a good place. The hormones. So it's really just a checklist, right? So when we look at the hypothalamus, they have a few things in common, right? They're all either releasing or they're inhibiting. So that's in the name. So if you see releasing and inhibiting, ding, 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 we're at the top of the HP axis, right? Good place to know, good place to start. If it's inhibiting or releasing, that we're in the hypothalamus. We're at the top of the axis. And then when we talk about the pituitary hormones, as I mentioned, we have many more in the anterior pituitary and then only a couple from the posterior pituitary, and they're all listed there for you. And we're going to get into each one, right? So I don't know if this will help you or not. I heard this once and it helped me. It's kind of a silly acronym. But for the anterior pituitary hormones, use a mnemonic. If it helps you, it means nothing but flat pig. You might have heard that before? Y'all have heard flat pig? I'm getting some yeses, some no's. Over in the other classroom, have y'all heard flat pig mnemonic for the anterior pituitaries? So flat pig, starting with the F. FSH, LH, AACTH, and then the T is TSH. And then for the pig portion is prolactin and growth hormone. So yeah, the I really, unless you throw in the I from prolactin, it doesn't start one of the hormones. But flat pig, FSH, LH, ACTH, TSH, prolactin, and GH. Kind of silly, like I said, means nothing, but once I heard it, it sticks for whatever reason. If it doesn't work for you, throw it away, right? And then I already mentioned the one kind of exception with the anterior, for the anterior pituitary hormones is, or specifically with the hypothalamic hormones, dopamine is the only hypothalamic hormone that is purely inhibitory by default, right? It suppresses prolactin, it does not stimulate it. Purely inhibiting. All right, so now we're going to start up at the top of the axis, right? The pharmacological applications and the specific drugs for the hypothalamus, either releasing or inhibiting hormones. starting with the GnRH agonists and antagonists, because probably the GnRH agonists and antagonists are arguably the most high yield out of the lecture, right? Some may throw in the antidiuretic hormones, but arguably GnRH agonists and agonists are the single high yield in the whole lecture. Anterior and posterior pituitary. So there's like 3 overarching reasons why the hypothalamic pituitary hormones, hypothalamic/pituitary hormones become a drug. Like, why are we here in pharmacology? 3 main reasons why those hormones can become a drug. So either you have too little of a hormone. So what do you do when you have too little of a hormone? You replace it. You got too little, you give more. Or you give something that is an analog that acts like our normal hormones that our body produces, right? Or we got too much. So then we can use pharmacotherapy to antagonize that, that hormone. If we're making too much, whether it's coming from the hypothalamus or the pituitary, too much of it, all right, let's antagonize that because we got to get rid of the excess. And then I gave you the third one, which was to conduct some testing, right? There's a couple of specific instances where we use some analogs to determine what the underlying disease process is. Specifically, is it a primary issue or is it a secondary issue? Which is the same concept that we talked about yesterday with the thyroid, right? When we talked about primary thyroidism, hypo or hyper, primary happens at what organ? The thyroid in hypo or hyper, because it's primary, it's happening there. So the same concepts, but sometimes we can use a synthetic analog of some of our hormones to determine if disease processes are primary or secondary causes, depending on the target organ. And also we can use a specific one related to the thyroid to determine if our surgery or ablation that we talked about yesterday is working or not. And we'll talk about that one when we get there. So pretty much as you work through the rest of the lecture, right, always try to determine which bucket of those 3, why is it useful in pharmacotherapy for the hypothalamus and pituitary axis? Is it because the pharmacotherapy or the drug that we're using is replacing something that's not being made, i.e. a hormone that's not being made adequately? Or is this drug going to antagonize it because the body's making too much? Or are we using it, usually it's something that's synonymous, a synthetic version of our normal hormones to use it diagnostically as a test, right? And we'll talk about those. But as you get through each of them, ask yourself, why are we using this drug when we get down into the specific medications, right? If you use that lens, that'll help you put them into these 3 buckets and it'll be easier for you to answer the questions on it and own it and understand it, not just memorize 1,000 different hormones, right? Or drugs. So this is just a repeat there of the hypothalamic hormones that we discussed on the last slide, right? Because that's the next topic we're getting into. All right, conceptual keystone slide for the entire GnRH section. So if it's GnRH, are we talking hypothalamus or pituitary or end organ? It's releasing hormone, so we're talking hypothalamus, right? Top of the diagram. Normal physiology, the hypothalamus is going to secrete GnRH, and this is important, pulsatile fashion. GnRH is going to be pulse delivered to the anterior pituitary through the portal system, right? Through those vessels, which is going to stimulate the gonadotrophic cells to release LH and FSH from where? Where it just went, right? Anterior pituitary. And we also remember our acronym, knowing that the FSH and LH is released from the anterior pituitary. And then the FSH, if you start looking over and looking at the difference between the FSH and the LH, what the two actions are. So in women, the FSH on the left is going to drive follicular development, or follicle development rather, and with the LH is ovarian steroidogenesis. So what's steroidogenesis? Anybody know? Yeah, making steroids, right? Making steroids. So where do steroids originate then? That's a bonus question. Like, what's a building block? Cholesterol, right? So we're going to steroidogenesis from the LH and FSH needed for the ovaries to make their steroid hormones. So, and then when we talk about the LH, it's going to trigger thecal cell and androgen production in men. Don't forget, men have FSH and LH too, right? So in men, the LH is going to, the FSH is going to drive spermatogenesis, so making spermatozoa, and then the LH is going to drive Leydig cell, which leads to testosterone synthesis. So it's all there on the slides for you. So huge paradox pharmacologically, right? What did we say normally GnRH is released? Constantly or pulsed? Pulsed, right? So pulse is going to stimulate the pituitary. That's how it normally works. And that's how we use GnRH therapeutically for hypogonadotropic infertility, because that's normal. If we have some issue with the FSH and LH, we give that pulsing to increase fertility, because we just said what LH and FSH does in both men and women. However, what if we give it constantly? What do you think happens? Castration, right? We shut it down, right? So, chemical castration in a sense. So down-regulating those receptors, so we completely suppress, or can completely suppress, the LH and the FSH with continuous dosing. So that's where the pharmacological application comes in compared to normal, compared to what our body normally does. And that's what those two white boxes are there, right? So the mechanism of action, when we talk about a sustained non-pulsatile administration, will suppress ovarian and testicular hormone making, steroid making, due to decreased levels of LH and FSH. So it's down regulation. So if we're going to give it sustained, initially what do you think happens? So I'm giving it sustained. What do you think is going to happen first when I start giving that? It's going to go through the roof, right? So we're going to call that a flare. So you need the important topic. If we give GnRH with a consistent dosage, continuous, initially everything goes up. FSH and LH are going to go up because we said it's down regulation. And we're going to give you a mnemonic or a little phrase to remember that on the next slide. But then if we give it, so we'll give it until it's done, right? So we'll give it and initially rises, then the down regulation happens, and then you'll get the shutdown of, in this case, the LH and FSH, right? And pulsatile, well, that's just normal, right? So if we're giving a GnRH and agonist, GnRH agonist, normally in a pulsatile fashion, then we're going to stimulate, right? We're going to stimulate. But you have to know that when we do sustain, there's an initial flare, initial increase until the down regulation can happen. So pulsatile stimulates, continuous suppresses. All right? Single concept pretty much explains every concept on the next slide, or clinical use that we're going to talk about coming up. So we also have this kind of, if you want to link it to something, if you learned about it already, we have in pharmacology a couple of other issues where this is kind of the same principle, right? So this continuous stimulation causes desensitization and finally suppression, right? So long-acting beta agonists You'll get that when you're talking in Pharm. And then chronic opioid receptor downregulation, bringing back in that pain lecture stuff. She talked about that, right? We don't remember that test is like gone, over, done. Okay. But it's just another example of how we use the pharmacology in that continuous fashion to downregulate and then finally cease the production of an N hormone. So make sure you know that the continuous causes the flare, then suppression. You will see it. It's important. Almost guaranteed to be on your pants. Anything else I want to say about this slide? So down at the bottom, that bullet under pulsatile. Pulsatile is normal. Yes, the second bullet may be a little misleading, but yeah, you're going to get that pulsatile administration to stimulate the cells to release LH and FSH during fetal and neonatal period, and then it's going to rise gradually, is what the box is saying, from 2 until puberty. That doesn't mean we stop, right? When we get to puberty, you still have to have FSH and LH for normal sex hormones. So it just abruptly is going to rise right before puberty, but we continue through adulthood, right? Until older age when it slows down. Just wanted to clarify if that's a confusing bullet on there. All right, so how do we use it? Just like we had the buckets for all of the HPA hormones, now we're going to talk about the clinical uses specifically for GnRH and LHRH. Really four main kind of buckets again that we can put them in. But they all kind of exploit that concept of sustained suppression, right? So prostate cancer, our medication there is jocaserlin or Zoladex, and then also Leuprolide or Lupron. And just like all the other lectures, these are kind of, some of the medications are kind of thrown into these different slides. I'll make you an overarching one too, like I did for the other lectures, so that you have one overarching, like all the drugs and what class that they're in. So it's already made, I just need to post it. I'll post it with some more check on learnings, probably this afternoon, and then some more tomorrow. But I'll get this drug list posted today. So once again, those two for the prostate cancer, the jocaserlin and the Lupron or Leuprolide, given as sustained to basically lower or chemically castrate the testosterone. So, and in prostate cancer, obviously, that's primarily androgen driven. So that's why we give those medications with that concept that if we give it continuous, initial flare, but then we're going to downregulate and stop the production, right? And then we also have gynecological hormone suppression. That's the jocaserlin again, and the Leuprolide and the neferilin. For endometriosis would be used, uterine fibroids, or any cause of ovarian hyperstimulation. This is an important caveat when we're using it for gynecological hormone suppression. We usually cap it at 6 months. So you see that noted on the slide under the ovarian suppression. And you see that the drugs are the same for ovarian suppression, or at least the Lupron and the Zoladex, or the jocaserlin and Leuprolide for both prostate cancer and ovarian suppression. And those are the examples when we would use it. Central precocious puberty, we can utilize this concept to stop precocious puberty, right? So if we have girls younger than 8 or 9 years old and boys where they're starting to show signs of puberty before those ages, then we can put in the neferilin acetate or the Lupron, the Leuprolide, as once again a continuous dose. So basically, just like we're using it in adults to chemically castrate, we're stopping the production. For these kiddos that may be going through precocious puberty, we put it on and we keep it going and shut down their puberty until they're at an age where it's appropriate to go through it. And obviously, this is beyond your primary care, realm, but you need to be aware of it. And we can also block endogenous puberty in transgender or gender variant folks. Yes. When you stop the medication, it will restart, right. Once the HPA axis turns back on, it will restart. The feedback loop will then reset itself. Yep. And like I said, be aware of it, know it. That's about the depth you need to know of it for our purposes. If you end up in endocrinology or fertility, some fertility assistant specialty, yeah, you'll get really in depth, or even pediatrics, if pediatric endocrinology. Highly specialized, but the board does expect you to know it, right? So we talked about the ovarian suppression and the puberty, and all in line with the precocious puberty, we can block endogenous puberty for transgender or gender variant individuals, and then also for assisted reproductive technology, right? So this is going to be fertility clinic use, but your patients may be under this treatment. That's why you need to be aware of it, right? Because it may change your treatment of other comorbidities, right? And there's the examples. In vitro fertilization, ovulation induction. Like I said, you need to be aware of it. That's about what's on the slide is about the depth you need to know for our purposes, and then just understand the complexity of what our endocrinologist specialists and our fertility specialists have to know to be able to treat these patients. That's what I get from it. It's so highly specialized, right? Pants does love the question about precocious puberty. I would know the age cutoffs and the first line pharmacological treatments. So the ages are there, and obviously this is the first line pharmacological treatments by name. They're under central precocious puberty. The neferolin acetate and the leuprolide. For the prostate cancer one, this comes up a lot, right? If someone has prostate cancer, a gentleman has prostate cancer, you're going to be expected to know the GnRH agonist suppression, i.e. the continuous dosing, giving you that initial flare before it comes down, because there's some contraindications or where a antagonist may be better, because the antagonists don't cause flares, which we're going to get into next. And so there's often board questions about gentlemen with prostate cancer, and you want to shut it down like we talked about there at the top, but if we do it with an agonist with continuing dosing, what's going to happen initially? Could be bad if you got prostate cancer, right? Or they talk about sometimes if you have like prostate cancer or some METs with spinal cord compression, and then you give the agonist, you have to give the antagonist first to prevent the flare, or probably better call just use the antagonist, which we're going to talk about next. But once again, back to that same concept of suppression through initial flares, right, and downregulation. But just know that you might see a board question related to that. So what do you know? If we're given agonist in a continuous fashion for GnRH or LHRH, adverse effect, most common, that disease flare. And so the signs and symptoms are listed there for you. Hot flashes, erectile impotence, decreased libido, bone pain, spinal cord compression, and that kind of uteral blockages. That kind of goes along with what I told you the board likes to test about having that, either some METs or having the prostate cancer with METs affecting the spinal cord, or uteral blockage. That initial flare could be worse. Adverse effects, these are, if you go back and look, they're injectable, so injection site reaction. And I think we talk about them a little bit more about the methods of delivery coming up, but mostly are all injectables. So obviously the adverse effects are logically from a hypogonadal state, talking about, after the flare. So a flare, and then when we don't have these hormones, then we get the erectile impotence or decreased estrogen causing hot flashes, things we talked about before. So it kind of logically follows. Let's see if there's anything else I wanted to talk about to you on this slide. The concept of, with the prostate cancer patient, if you are going to do an agonist, right, which the drugs from the last slide, usually put on the antagonist first to keep the flare down, which could be dangerous, right, worsen their condition, or just use an antagonist. So we're going to talk about that in the upcoming slides. Boards do love that question, though. Okay, so back to the medications. So I'm going to, just like always in Pharm, we're going to have the generic, and we'll put the brand name there too. A lot of folks recognize some of the brand names easier, but we put them both there, right? So you need to identify them one of two ways. And like I said, that chart, and there's some charts further in the slide deck, but I'll make an overarching one so you have one to go to. But yeah, you definitely need to be able to pick them out of a lineup, right? You can just see, I'm not going to ask you about the dosing or the mode of delivery, but you can see most of them. You can have an implant for the Jerserelin, then the Lupron. You have differing dosage for the depot. What does the depot mean? It means we're injecting it and then it's going to release its medications over a long period, right? So the depot, we're going to inject it and then over a long period, but depending on which version of the Lupron you're using, there's a 1 month, 3 month, 4 months, 6 months, so just longer action of those depots. You don't need to know all the different dosing. You do need to be aware, though, of the Neferilin, the Cinerol. That's the only one that's a nasal spray. So you can, if it's talking injectable, you can take Neferilin off of your possible, right choices, because that's the only one that is a nasal spray. So I would know that. Like I said, the rest of them are either injections or they're sub-Q, or they're IM, or you have an implant. Not that real deep depth, but I would certainly know the Neferilin and the Cinerol mode of administration being a nasal spray. Okay, so the antagonists, what's their MOA, right? They bind to the pituitary GnRH receptors via competitive blockade, which causes immediate suppression of LH and FSH. So, if they cause immediate suppression, is there a flare with an antagonist? No, because it binds to the receptors, so it's immediate. No flares with the antagonist, right? So no flares with the antagonist. They turn it off immediately. They turn off those receptors for GnRH, persistently blocking it, so there's no surge or flare. So there's a bullet there, a memory mnemonic, if you will. Just agonists stimulate the receptor until it cannot be stimulated anymore, equals flare, right? Agonist will stimulate until exhausted, and antagonists say no from the start. I remember that way. Agonists stimulate until exhausted, antagonists say no from the start, if that helps you. If not, whatever you come up with, as long as you understand the concept. So the agents there for the antagonists, right, are inhibition of premature LH surge in women undergoing controlled ovarian hyperstimulation procedures. Usually this is going to be used in your fertility clinics, right? So there's your agents. They're both sub-Q, the Generelix and the Cetrelix. Kind of same suffixes, and a lot of these do. So if you go back and can figure out if you can put things into groups based on their suffixes, please do. I didn't point it out on the other slides, but it's easier to see when you look at an entire list. But just make sure you make those connections if they're there for you. And then same suffix, the Elix there for the men. The Degerelix is going to be used for advanced prostate cancer. So that's why the Degerelix for advanced prostate cancer is preferred, because the antagonist will not cause a flare. Right? I have kicked the horse enough, right, everybody? We got that concept. All right. But it shows up time and time again. Let's see if there's anything else I want you to know about that. Yeah, the adverse effects are milder for the antagonist versus the agonist, right? Just nausea, headache. Once again, you see a lot of them are sub-Q, so there's no local, you have just some local site reactions, right? Redness, swelling, bruising, itching. Notice we haven't talked about anything that's a nasal spray in the antagonist either, right? So that's why knowing the one-off difference kind of can help you in some scenarios. I would say that, the question stem that you'll see on the board, prostate cancer, you going with Leuperolide or you going with Degerelix? Degerelix, right? Because no flare. All right, so this is just a comparison table, right? Agonist versus the antagonist. All the things that we've talked about. The flare, the increase initially, and then you'll notice on the agonist analog side, sometimes we use an antagonist to compete with it, right? And we talked about that when we discussed briefly the prostate cancer approach using an agonist versus an antagonist. And like I said, may cause temporary rise in PSA because of that surge in testosterone. Versus antagonists, on the right, immediate complete suppression of LH and testosterone. So PSA, in the case of prostate cancer, suppressed more quickly. No risk of surge, FSH and LH. And that brings us to the break. So we'll be back at 11. All right, shifting gears, right? We've been hanging out at the hypothalamus. We're traveling down the HPA. Now we're going to get down into first the anterior pituitary. And we talked about what those were. And remember the mnemonic, if it helps you, from what the hormones that are released from the anterior pituitary. All right, so the flat pig. Once again, this is just a blow up of those end organs. And then we took since we're lower in the HPA, lower in the hypothalamus pituitary axis, so we removed the hypothalamus so we can focus in on the anterior pituitary and then also the two hormones of the posterior pituitary there, which we'll get to tomorrow. So once again, ask yourself which end organ is each of the hormones from the anterior pituitary acting on. GH going to be on the bone, muscle, and liver. Liver through that the insulin growth factor 1, which we'll briefly discuss, and hopefully that's a review for you. TSH on the thyroid, ACTH on the adrenal cortex, and then FSH and LH, which we just finished talking about, on the gonads, the ovaries, and the testes. And then prolactin on the breast, which is, we said, our exception to the rule, which is negatively inhibited by the dopamine. So last kind of pure physiology slide, and then we're digging right back in to the disease processes and the pharmacotherapy. So just know that for your pants, right, for the testing on the pants, usually you're going to see the end organ finding, right? When we're talking about anterior pituitary, usually it's going to be that end organ finding, the ones we just mentioned and they're on the slide, right? So like galactorrhea or coarsened facial features or hyperpigmentation. They give you that end organ root causing something that you're seeing with your patient, and then you have to kind of work backwards to get back up to the pituitary and figure out which pituitary hormone, and then we determine what drug we're going to use, if any, to affect it. And they're all listed there for you on the left. The hormones from the anterior pituitary. So pretty much organize your anterior pituitary hormones into hyper versus hypo, right? Too much or too little, because treatment obviously is going to be determined by which bucket we put them in. Too much, too little, or are we using something to do a diagnostic intervention, that third bucket of how we use pharmacotherapy in the HPA axis dysfunction. So when we talk about hypersecretory, there on the left, acromegaly, gigantism, and we're going to dig into it, but acromegaly in adults after the growth plate closure, and then gigantism is in children before growth plate closure. They are two different disease processes. They're acting on either adults or kids, so don't put them as the same. They're separate conditions, as the slide says, but they're both a hypersecretory disease of growth hormone. Just a matter of when we're getting the increased growth hormone release. So a lot of these drugs in the anterior pituitary is going to be from a tumor, right? It's going to be from adenomas. So hyperprolactinemia is usually a prolactin secreting adenoma or prolactinoma. You'll hear it discussed, and that's what you see on the slide. You can get the hyperprolactinemia from certain medications or certain lesions in the CNS. And then moving over to the right is the hyposecretory diseases of growth hormone specifically. And so that's the congenital abnormality. It can be inherited, right? It can be genetic, so caused by a GH gene deletion or a GH releasing hormone deficiency, i.e. up at the hypothalamus. We can have pituitary aplasia, so you're not making a pituitary congenitally. You can get some traumas or an infection that cause a decrease of growth hormone synthesis. Or it can be idiopathic, something else that we don't really know is just happening, right? Essentially, all the anterior pituitary disease processes we're going to talk about, almost all of them are going to be traced back to an adenoma. Going to be traced back, and then when you get into endocrine, they're going to talk about the sizes and what they're made of, or they're micro or they're macro, and then how they're treated. But just know that for anterior pituitary diseases proper, as a whole, they're caused by an adenoma. And then if you want to know the size, just as a reminder, so microadenomas are usually less than a centimeter. Kind of easy to remember. And then macro, above a centimeter. So panhypopituitarism, down on the bottom right, partial or complete loss of anterior and posterior pituitary function. Everything, the entire pituitary. So it can be caused by a pituitary tumor or a primary pituitary tumor, trauma, right? Or irradiation. So if you're exposed to radiation, it can shut down both the anterior and the posterior pituitary. So what is it going to result in? Well, everything's going to be decreased. All of the flat pig hormones are going to be decreased. What do you think is the most dangerous? Trivia. If we lose all the hormones, what's the most dangerous? We haven't talked about it much yet. That first one under results, right? ACTH, right? Adrenal crisis. You might have talked about it. We talked about it briefly yesterday in thyroid storm, in that we're going to throw steroids in to make sure, thyroid storm and myxedema, throw steroids in to make sure we're not in adrenal crisis as well in those two end states of thyroid disease. But yeah, that's considered the most dangerous. So would you worry more about replacing ACTH or your G8, your growth hormone? ACTH, right? Yeah. Growth hormone can wait. So acromegaly, too much GH. It's acting through the IGF-1, the insulin growth factor 1, in the soft tissue and bone. Classic exam findings, and you got some pictures there for acromegaly, too much GH, in a child or an adult? An adult, right? Because the epiphyses have already closed. So classic findings, excessive sweating. What's that called? What's the medical term for excessive sweating? Hyperhidrosis, right? Excess sweating. Osteoarthritis, joint pain, paresthesias, so some numbness, some tingling. And that's coming from soft tissue and cartilage overgrowth. Also, a lot of these folks will have carpal tunnel syndrome or median nerve entrapment. So there's a big cluster of signs and symptoms that we see with too much growth hormone causing acromegaly. Coarsening of the facial features, what's that mean? You lose the fine lines of the face, they look coarsened. Also frontal bossing, what's that? Yeah, that protruding forehead. Just look at the picture on the kind of middle left there. You don't really see the forehead, but you see the prognathism is what the term for that protruding jaw. It can be the upper or the lower, and that can start to interfere with the ability for the patient to eat. But prognathism is that protrusion beyond normal alignment that you see. The picture's labeled 100 for whatever reason, but you see the protrusion of the lower jaw there. It can happen upper or lower. Classically, there will be discussion in vignettes on your boards about increased hand or ring size and shoe size. Right. We used to have I think they still do an endocrine. There's a picture of a well-known baseball player who's a pro showing when he was young on the team versus later in his career, the difference in the size of his head. Because we'll talk about growth hormone can be abused, right? Because it decreases fat, increases lean muscle. So folks, sometimes bodybuilders, other athletes, no proof. I'm not saying anything other than there was a picture showing a change in the size of the head, and I think also his batting average was a lot better too by that time. But so enlargement of the hands, shoe size, and that's what it's showing on the top left, an increased hand and ring size. With growth hormone, we can also have too much causing cardiomyopathies, and also we have some issues with hyperglycemia. So folks with too much GH, and we'll talk about why that happens as we move further through the lecture, but just know that hyperglycemia, hypertension, heart disease, all that goes right along with acromegaly. It's not just a disease of the hands and the head, right? And you'll also sometimes see in the stem sleep apnea increase from overgrowth of the tissues in the airway, because when we talked about the GH and where it acts on end organs, well, IGF-1 is throughout the body, right? It's not just in a one target organ. We talked about the bones, but the cartilage is also affected numerous other locations throughout the body. So there's systemic effects, not just a disease of a big head and big feet, right? Or big hands. Takes a long time for acromegaly to be diagnosed because, when you're around someone daily, often, if there's slow changes, you don't tend to pick up on it, or you don't pick up on it yourself looking in the mirror, right? Or when you see others, because it's a slow process. So it's when it becomes very obvious, or someone maybe that doesn't see you every day or you haven't seen in quite a while starts to go, hey, you look different. Or you start to notice, hey, my ring size is, I can't get my wedding ring on anymore. I can't get my rings on anymore. Or why am I buying a size 15 shoe when I was a 10 and a half, 2 years ago? So slow action. So it's often late when it's diagnosed. And yep, I think I hit all of the things I wanted you to know for Pat. So for GH is pattern recognition, right? Acromegaly, too much GH, all those signs and symptoms, and recognize that pattern in a vignette. They're going to give you a few clues, and on our test, we'll give you the clues. So what are the goals? To reduce the GH. Is too much? Reduce it. And also because GH is causing an action at that insulin growth factor 1, sometimes and often we monitor the growth factor actually instead of GH, and we'll talk about why. So often the goal is to decrease the IGF-1. So we can use that as a monitoring tool, not just GH. So how do we diagnose it? Specifically, we'll notice after an oral glucose tolerance test, we'll have a suppressed GH, right? A suppressed growth hormone after an oral glucose tolerance test. So normally it's going to suppress it, but then in acromegaly, it doesn't. It's going to go up, right? The glucose does not suppress the growth hormone in acromegaly. First line, this is different from everything else. First line surgery. First line is surgery. Surgical resection of the tumor is preferred if the tumor is causing too much of the GH. Pharmacology, we use it. There's the agents on the bottom right, but it's reserved for a few scenarios, right? Often we're going to use those pharmacological agents to reduce the size of the tumor before we do surgery. Or radiation, if that's the definitive treatment. Or if we can't do surgery, we go to meds, right? That's kind of intuitive. Or we do surgery and it fails and the patient relapses. And once again, GH is overproduced. Okay, now we have some agents there on the right that we can use to control the GH and IGF-1. So clinical pearl, just remember that the failure of growth hormone to suppress, to decrease after an oral glucose tolerance load is the key confirmatory test. Not a GH, not an IGF-1 for diagnosis, right? It's the failure of the GH to go down after an oral glucose tolerance test or oral glucose load. And then definitely remember, best initial treatment for acromegaly, transsphenoid surgery. Always think surgery first for acromegaly and not the agents. So somatostatin is growth hormone inhibiting hormone. It isn't just hypothalamic, right? It's produced by neurons throughout the body and the intestines and the pancreas. So it's a broad inhibitory hormone. As it says, it's growth hormone inhibiting, somatostatin. So what does somatostatin do? Broadly inhibits, so it suppresses GH, but it also suppresses glucagon, insulin, and gastrin. So that tells you why that we can have those problems with blood sugars, because it's broad. Somatostatin, the growth hormone inhibitor, is suppressing on the growth hormone, but also glucagon, insulin, and gastrin. So the key limitation here is that our endogenous somatostatin, very, very short half-life. And it hits all those systems at once, which we just mentioned. So it's the native hormone that our body makes, not really useful, and that's why we use a synthetic analog for therapy in the pharmacotherapy for growth hormone inhibition. And that's what's on the slide there. Very short half-life, multiple effects, and we mentioned them, and it's there on the bullet above it that the somatostatin that our body makes is going to inhibit the release of growth hormone as well as glucagon, insulin, and gastrin. So it's not just working on growth hormone. So that's why somatostatin or the synthetic analogs we're going to talk about that inhibit growth hormone causes those other issues, right? That's why they can cause a problem with either too high or too low of the blood glucose, And then we'll talk about folks and why we use some of the somatostatin analogs and how we use them in the next couple of slides, and why those folks, because they're on a growth hormone inhibiting synthetic hormone, we have to monitor their blood glucose if they're on one of those medications. And that's coming up on the next slide. You do need to know somatostatin's normal inhibitory targets, right? And I gave them to you and they're on the slide. That second bullet, I would know it. So it's growth hormone, but it's also glucagon, insulin, and gastrin. And because it helps you understand the adverse effects of giving a growth hormone inhibiting hormone. So growth hormone inhibiting hormone, somatostatin mechanism of action, binds to the pituitary somatostatin receptors and block growth hormone secretion. So it's antagonist at those receptors, which means it also inhibits insulin, glucagon, and gastrin secretion. So how do we use it? Reduce symptoms caused by a variety of tumors, right? For acromegaly, like we mentioned, for growth hormone, and we also use it for control symptoms of secretory diarrhea, which are caused by those VIP tumors that are listed there. So those are kind of rare pancreatic tumors, but they cause a secretory hormone release, and they can give you some bad secretory diarrhea. So we use it for acromegaly and the diarrhea from a VIPoma. You'll see it sometimes abbreviated VIPoma. And like I said, those are they're secreting tumors, hormone secreting tumors. So it's the growth hormone inhibiting hormones are not just for acromegaly, is the key take home point, and know what their other uses are. A big one is your workhorse there, IV, on that last bullet on the left, the octreotide. You'll see this, and matter of fact, so after you take your pants, and then a few years later, you either have to go sit the PANRE, right? Or the newest thing is they do a PANRE longitudinal assessment where they give you a number of questions throughout 2 years. You have like 20 questions a quarter for 2 years. And so I was just finishing up another recertification last semester, and the IV octreotide for esophageal varices bleeding was on there. So it's showing up. It's a workhorse drug. But that's why I say remember that the growth hormone inhibiting hormones are not just for acromegaly. There's octreotide, and there's more on it up on the top right there. The sandostatin is huge for esophageal bleeds, esophageal variceal bleeds in an emergency setting. So it'll come back. You'll see the octreotide or the sandostatin again and again, especially in those emergency situations for upper GI bleeds. Notice that the somatostatin analog, $, very expensive, but it's very effective, and it's 40 times more potent than endogenous somatostatin. So it's a very, very potent drug. For the esophageal varices, you're going to get it later, but basically it has an action at vasoconstriction of the splanchnic blood flow. So the GI and mesenteric blood flow, they put the octreotide on board because it clamps down that. And if you have an upper GI bleed, well, if you're clamping down the vessels of the GI tract and the mesentery, that helps you control the bleeding of the emergency situation of esophageal varices bleed. All that's a little more deep than we're going to go into Pharm on it, but you'll see it again. So you need to be familiar with octreotide being used as a growth hormone inhibiting hormone, not just acromegaly. And it's very potent, but costly. And let's see. The adverse effects of the growth hormone inhibiting hormones. So the octreotide or the lanreotide, once again, you got a sounds like suffix there to pick them out of a lineup. Adverse effect, diarrhea, nausea, so a lot of GI effects. Steatorrhea, so those fatty stools, steatorrhea. Can cause some arrhythmias, can lead to hypothyroidism and biliary tract disorder. So make sure you familiarize yourselves with the adverse effects of the growth hormone inhibiting hormones. Used both for acromegaly and VIPomas, or any, and then the acute controlled esophageal varices bleed. I haven't seen the lanreotide mentioned for the esophageal bleed, only the octreotide. So now we move into the growth hormone receptor antagonists, right? The pegvomastat, pegvisomat, or somavert. So what does it do? It binds to growth hormone receptors on the cell surfaces. So on the target organs, right? The liver and the peripheral tissue, where it blocks the binding of GH. So once again, it's a GH blocker, but it's now down at the target organs. So it interferes with the GH signaling pathway. So it's completely different from the somatostatin analogs because it does not lower GH secretion. It binds to the receptors, it blocks them there, physically blocking the endogenous GH from signaling, which is going to drive down that IGF-1, downstream mediator of the clinical side effects. Clinical use specifically for acromegaly, resistant or unable to tolerate other therapies. This is that case where I said surgery didn't work or you can't have surgery. Then you're going to look at the growth hormone receptor antagonist, pegvisomat, somavert. So you're going to use it to block those peripheral receptors only if your patient can't have the definitive treatment of surgery or surgery fails. Some of the same adverse effects that we mentioned on the last slide, so nausea and vomiting, some flu-like symptoms. We do have a reversible elevation of hepatic transaminases with the pegvisomat or somavert. So you'll see this one on the pants. Often it's a trick, right? Often it's a trick. You're going to get signs and symptoms of increased growth hormone or acromegaly, and then it's going to ask you surgery or this, and people are going to want to jump to this when this is only if it's you can't have the surgery, surgery is contraindicated, or you've already failed the definitive treatment of surgery. Right? So don't fall for that trap. Also, you're going to see here people, another one that shows up, and you may see it again, is that you can be put on the somavert, and then when I draw your GH levels, are they going to be decreased? Think about the mechanism of action of the drug. What does it do? So I put you on this medication for your increased GH, and then I draw GH, and I go, shouldn't it be down? No, right? Because it's an antagonist at the target organs. So don't fall for that trap either. So what do we use? What do we trend for when we use this medication? IGF-1. Because will it go down? IGF-1 will, right? It should go down. So don't look for GH changes with somavert. Look for IGF-1. It's not treatment failure, you're just testing the wrong hormone. Okay, so now we're talking too little. We're just flipping the pathology. Not enough growth hormone. So the somatotropin, GH, released by the anterior pituitary, is under the growth hormone releasing hormone stimulation from where? It has releasing in it. Coming from the hypothalamus, right? Excuse me. So most of the effects are exerted on IGF-1, just like we mentioned on the last slide. IGF-1 in the target organs. So most of the effects from too little are going to show up because the IGF-1 is not going to be stimulated. And those are the locations on like the third bullet down, right? So if there's not enough GnRH, or growth hormone, from the anterior pituitary, we're not going to have enough production of IGF-1. And the target, same targets as we talked about with too much, bone, cartilage, muscle, kidney, throughout the body for IGF-1, but mainly produced in the liver. So those growth hormone promoting effects that we're going to get are mediated by IGF-1. So somatotropin is going to stimulate longitudinal bone growth until epiphysis close near the end of puberty. So if we don't have enough on board, guess what? We don't grow as much. Our patients don't grow as much when they have a deficiency. So this growth hormone, somatotropin, required during childhood and adolescence for obtaining normal adult size. And as we, get beyond puberty and those epiphyses are closed on our long bone, we still need the growth hormone there, right? For the lipid and carbohydrate metabolism, effects on lean body mass, bone density, and this is where we get into is potential for abuse, right? Human growth hormone or somatostatin, because of those effects in adulthood, like lipid breakdown, lean muscle mass building. So folks that want to obtain those things sometimes try to obtain it through somatotropin. So potential for abuse because you're going to increase utilization of glucose by peripheral tissues. You're going to break down fat more, and your muscle mass is going to increase. So that's what I was talking about with that abuse potential. And remember that the IGF-1 is a correct lab to trend for both the GH replacement coming up, right? If we're going to give somatotropin, name brands, gonadotropin and humanotropin, we'll talk about why. We're trending the IGF, not just the GH. Also, when we start treating for too much, we mentioned it, especially with the antagonists. So in kiddos, treatment of growth failure due to inadequate growth hormone is how we're going to get after the decrease in growth hormone. There's certain patient populations that have some genetic disorders. We're not going to get real deep into this in this class, but short stature that's associated with an inherited like Turner or Noonan syndrome, or short stature homeobox gene called SHOX deficiencies. I'm not getting into the pathogenesis of those or the pathophys. Just know that growth hormone failure can be caused in kiddos due to some of these inherited short stature diseases. Also, we can get growth failure due to chronic renal insufficiency in our kiddos. So growth failure in children that are born small for gestational age. So if they're small for gestational age and they don't catch up by 2 to 4 years, then we can start talking about growth hormone pharmacotherapy to help them get there, right? To get them of whatever their normal height was going to be, the bone growth. Specifically, there's a bullet here about Prader-Willi syndrome, rare disorder, present at birth, results in several changes, one of them being short stature, but there was also some mental and behavioral problems and some other physical changes. But you may see that one as, just know that if you see a vignette, short stature, for their age, that one of these associated genetic disorders such as Turner, Noonan, or Prader-Willi may be there, be able to recognize them. You don't know, not for this course, you do not need to know what all those mean. Just know that those genetic disorders are associated with short stature when we could use growth hormone replacement or somatotropin replacement. Let's see here. And then the picture down at the bottom is just showing on the left the growth hormone deficiency in the child that is short stature for their age versus a normal child. And then on the right, we can use growth hormone for adults as well when they have like a muscle wasting syndrome, often associated with things like HIV, or adults with a growth hormone deficiency. And then there's a specific GI issue, inherited issue, short bowel syndrome. We'll talk about it briefly in GI next semester for you guys. The juniors have already had it. So here's one related to yesterday's lecture. So thyroid stimulating hormone, thyrotropin. Now we're into the third bucket. It's not too much, it's not too little. We're using it as a clinical diagnostic tool. So you need to know that. Thyrotropin, we're using a thyroid stimulating hormone, thyrotropin, as a clinical tool. So completely shifting categories, not a treatment agent. So thyrotropin alpha is the agent, or thyrogen. So this is the synthesized version, right? There in the bottom is recombinant human TSH. So we use this after a patient has had a thyroidectomy. So if they've had that definitive treatment of a thyroidectomy, and we talked about that usually being the definitive treatment, most commonly the I-131, but in some cases we have to use surgery. So after we do that surgery, we're going to use this medication, the thyrotropin alpha or the thyrogen, to basically stimulate any residual thyroid tissue to take up radioiodine and produce thyroglobin. So we're going to detect if there's any recurrent residual disease going on. So basically, when we give the surgery, what happens to the patient? We talked about it. If we have the surgery, then what's going to happen to the patient? Thyroid related. They're hypothyroid, right? So if you just keep them in that hypothyroid state and wait for that axis to reset, you're talking about a miserable patient who's hypothyroid for a number of months, right? A number of months. So we can use this medication to see if there's any residual disease process left. If not, now we can get them on thyroid stimulating hormone. Now we can get them on Synthroid. You just dramatically improved this patient's life for a few months because you did not keep them in a hypothyroid state and then retest their TSH and their free T4 months from now, right? Remember how we talked about how long it takes to regulate and why we have to bring the patient in and check their TSH and their free T4 at certain levels, and it takes months to kind of get there, or at least numerous weeks, right? 6 weeks or so. So using the thyrotropin alpha or the thyrogen after the surgery, then we can go in and then check the markers. You don't have to know exactly how the test is done, but basically it lets us know if there's any residual thyroid disease happening, and if not, then we can get them out of their hypothyroid misery by go ahead and starting them on thyroid replacement. Normally, what medication? Synthroid, I'm hearing, right? That's right? I think it's right. Okay. So this is back to the buckets, right? Too much, then we have to stop it. Too little of a hormone, we have to add it. Third class, and this is the first one that we talked about, we're using it as a diagnostic test. So basically we're sparing our post-thyroidectomy cancer patient weeks of symptomatic hypothyroidism by being able to check thyroid function or dysfunction after the thyroidectomy with thyrotropin alpha or thyrogen. Switching gears again. So the adrenocorticotropic hormone, ACTH, aka corticotropin, from the anterior pituitary still, right, drives adrenal cortisol and androgen production from the adrenals. The synthetic agent is casinotropin or cortricin, and we'll talk about that. I don't think it's on this slide, on the next slide. But once again, that medication is going to be used not as a medication. That agent is going to be used like we use the thyroid agent. We're going to talk about primary versus secondary adrenal cortex disease using the casinotropin, just like we did with the last medication for the thyroid, or the last agent. I won't call it a medication because you're not treating anything. But once again, that third bucket is going to show up as diagnostic testing modality with the adrenocorticotropic hormone, casinotropin. to see if the adrenal gland is going to respond to an ACTH stimulus or adrenocorticotropic hormone stimulus from the anterior pituitary. But instead of it coming from the anterior pituitary, we're going to put it in. And we'll get more in depth on it, and we'll talk about normal versus abnormal responses, but hugely, highly testable. So primary adrenal insufficiency, you've probably heard of it. Anybody know primary adrenal insufficiency? What's the name of the disease? Starts with an A, rhymes with Addison's. That's it. Addison's disease, right? Primary adrenal insufficiency, Addison's disease. What happens here is your adrenal cortex is destroyed, right? It can't make cortisol, it can't make aldosterone, it can't make androgens. No, the androgens are those steroids or those hormones that are converted in the periphery to testosterone and estrogen, so precursors to testosterone and estrogen, not from FSH and LH, but things like DEHA. Anybody ever heard of that before? Like dehydroxy, epindosterone, precursors to estrogen and testosterone. Or androstenedione, maybe I've heard of that one before. But basically, once your adrenal cortex is shot in primary adrenal insufficiency or Addison's, you cannot make cortisol, aldosterone, or any of those androgens. No matter how much HTH, ACTH from the anterior pituitary, or CRH, a corticotropic releasing hormone, is present, you're not going to get any cortisol out of an Addison's disease patient because the adrenal cortex is fried, right? And because there's no cortisol to provide negative feedback, ACTH and CRH are just going to go up and up and up, much like TSH does on the thyroid, right? If there's primary thyroid disease. Let's see, I think I hit that. Yeah, so the lack of that negative feedback is because the cortisol, remember our example on our very first slide, we could think about all the HPA for the anterior pituitary, and we talked about cortisol being that feedback loop to the hypothalamus and the pituitary. Guess what? Ain't none in Addison's, right? So ACTH and the CRH just keep on trucking, keep pumping. But no matter how hard they try, the adrenal cortex cannot produce cortisol. So a cause of secondary adrenal insufficiency, they're listed there on the bottom. The biggest one is the reduced glucocorticoid production secondary to decreased ACTH levels. And your common cause is that next bullet, sudden cessation of exogenous steroid use. So we've talked about it in numerous classes. If we've been giving steroids, we try to use the lowest dose for the shortest amount of time possible, because when we either keep them on too high a dose, our patient, or we keep it on a dose for too long, then that's what happens to the ACTH, right? ACTH drops, and then it's going to suppress that HPA axis, and then we're going to have decreased levels release of ACTH. So then we're going to have impaired androgen or cortisol production, i.e. secondary adrenal deficiency. So make sure you know that that pathway for the secondary adrenal deficiency. That's why you always ask about steroid history, right? And don't forget about our asthma patients. Even at a young age, they may be getting inhaled steroids. So steroid history is huge when you start talking about endocrine pathologies. And I know some of you have to do height, weight, right? Okay, so just a few folks. Let's see. You know what we'll do? So we'll just go ahead and stop here. We're almost done with the anterior, and then we'll finish up the first hour tomorrow, because I don't want to put out things and then miss it. Wouldn't be fair to them, because they didn't schedule the height, weight during, happened to be over there right after lunch. So we'll stop here, and then we'll pick up tomorrow. We'll get finished pretty quickly tomorrow, and then I'll do kind of a quick, I'll probably just go through the memory jogs, and I'll have all the other check on learnings and this lecture's med list there for you. And we'll do kind of a quick review, not a full review because you still got diabetes, but a quick review of what we've gone through in the lectures that I provided Friday and then this week. And then you'll have a lot of time to chew on that, and you'll have lots of things to look at, like the memory jogs and the check on learnings, which are just high yield. They're not clinical vignettes like we're going to test you. It's just high yield. Can you pick this important thing out? And do you understand the differentiators and why wrong is wrong and right is right? But then we'll also look at next week, for both cohorts, after diabetes, since Major Hart is going to be on leave the rest of next week, before the Friday test, we might see if we can find like a 30 or 40-minute lunch, voluntary only, quick review, maybe, just to make sure we incorporate the diabetes stuff, or if there's any questions, because there's kind of a long lag between tomorrow and when you take the test, and then a short piece between when you get diabetes and take the test, like 4 days. So any questions? I'm in my office not until I'm given a retake of a test, so probably not until like after 1500, but I'll be over there if anybody has any questions. And other than that, hope you guys are done for the day, right? So y'all are going to go